Hi, this is Dr. Bhargava, and in this video, I'm going to talk about PSMA PET-CTs and some interesting cases that we have come across. Let's start with brief description of the radiopharmaceutical and how it works. So we have two approved radiopharmaceuticals in the United States, gallium-68 PSMA-11 and an F-18 labeled agent. They were approved at different time points in 2020 and 2021 respectively. The physical half-life of gallium-68 is 68 minutes and of F-18 is 110 minutes. The mechanism of uptake of this radiopharmaceutical is binding to PSMA or prostate-specific membrane antigen. The dose is different for when we want to use gallium-68 versus F-18. We wait for 60 minutes, so the injection to imaging time is 60 minutes. The indication is diagnosis, staging, and restaging of patients who have prostate cancer. There is physiologic uptake seen in the lacrimals, the salivary glands. There is excretion from the kidneys into the urinary bladder, and there is physiologic uptake in the liver and spleen. There can be false positive uptake, meaning that there is uptake but there is no prostate cancer there. This can be seen when there are other cancers which can take up PSMA, degenerative changes or fractures. There can be false negative uptake when there is prostate cancer, but there is no uptake of the radiopharmaceutical. Remember, about 10% of the prostate cancers are negative for PSMA. Here is the whole body rotating image from a F-18 PSMA PET-CT showing characteristic uptake in the lacrimals. There is uptake in the salivary glands. There is excretion from the kidneys into the urinary bladder, some faint small bowel activity, and some uptake in the liver and the spleen. So PSMA is a type 2 transmembrane glycoprotein. It is expressed 100 to 1000 times in prostate cancer cells, especially when they are high grade, castration resistant, biochemically recurrent, or metastatic tumors. Compared to conventional imaging with PSMA PET-CT, there is greater accuracy, higher sensitivity and specificity, fewer equivocal findings, and overall higher detection rate for prostate cancer. Both of these radiopharmaceuticals have similar biodistribution and diagnostic characteristics. They are tolerated well with no adverse effects. This is a table describing the physical properties and comparison between the two agents, F-18 labeled and gallium-68 labeled agents. And this is from this article that was published in Abdominal Radiology. Here is another good article published in Journal of Nuclear Medicine. They talk about the appropriate and the maybe appropriate and then the really appropriate indications for use of PSMA PET-CT. Here is one of our patients, and on the rotating image, there are multiple foci of increased uptake in the prostate, consistent with prostate cancer, and that finding is shown here. Here is this low-dose CT, which was acquired without contrast, and so it doesn't show much except that there is soft tissue density in the prostate, and we overlay this image with this PET image showing multifocal prostate cancer. The value of this study is that there is no evidence of metastatic disease, so the patient can undergo definitive treatment. Here is our next patient, and on the rotating image, we find physiologic distribution. There is prostate cancer on the left side, and here is the primary cancer involving the left peripheral zone of the prostate, and there is extension to involve the right peripheral zone, and there is extension to involve the right seminal vesicle. And so sometimes you can pick up findings based on the CT part of the PET-CT. So here we picked up seminal vesicle involvement. Here on the rotating image, you can see that this focus extends superiorly and laterally, and that's where the seminal vesicles are, like we see here. So there is locally advanced tumor, but again, there is no evidence of metastatic disease seen as PSMA avid focus on this PET-CT. This is our next patient, and here again we see focal uptake in the prostate, which is the primary prostate cancer. And this focus is located in the right peripheral zone. And here what I'm trying to show you is concordance with this patient's pelvic MRI, where we see this low signal intensity on T2 weighted images, which is characteristic of prostate cancer. We see high signal on DWI and low signal on ADC, which together is called restricted diffusion. This is our next patient. They've had prior prostatectomy and they presented with rising PSA. Let's take a look at their rotating image first. So we see uptake in the pelvis. This is likely in the urinary bladder. And remember, after prostatectomy, the inferior aspect of the urinary bladder becomes funnel shaped, and so it can look funny on these images. There are two foci of increased uptake that suggest metastatic disease. They correspond to this sclerotic focus in the right side of the sacrum, a bone metastasis, and then a soft tissue focus, a lymph node in the retroperitoneal para-aortic region. So we have identified metastatic disease in this patient who was treated with prostatectomy and presented with rising PSA. This is our next patient, and we find that below the urinary bladder activity, we see multifocal prostate cancer, and we see multiple foci of increased uptake, which are consistent with metastatic disease. These involve a focus in the clavicle, a focus in the spinous process in the thoracic vertebral body, and another bone focus in the right side of the ilium. So they have multifocal bone metastases as seen on Psma Pet-Ct. And so the CT images are of value because prostate cancer metastases are sclerotic or bone forming, also called osteoblastic. And when we see focal uptake that corresponds to a osteoblastic focus, that increases our confidence in calling metastatic disease. This is our next patient. They've had definitive treatment and they presented with rising PSA. And here the interesting finding is that we see uptake of PSMA in a very tiny focus right there on the rotating image. And this focus corresponds to a 3 millimeter nodule seen on the CT part of the PET-CT. So very tiny sub-centimeter foci of metastatic disease can be picked up on PSMA PET-CTs. Here is another patient. Let's take a look at the rotating image. We find this focus here in the pelvis, and that focus corresponds to this tiny lymph node in the right side of the pelvis, seen here showing focal uptake. So that's metastatic prostate cancer. This is a patient that showed unusual pattern of metastatic disease on PSMA PET-CT. Sometimes prostate cancers are very aggressive and they can metastasize to atypical sites. Like, let's take a look at the rotating image first. So we see lacrimal gland uptake, and then we see two foci of increased uptake in the brain. Also, we see excretion from the kidneys into the bladder. We see metastatic disease in the retroperitoneal para-aortic region, and also some funny looking foci in this patient's penis. So here's the tumor in the prostate. This is retroperitoneal para-aortic lymphadenopathy here as well, and two foci in the brain which correspond to these hyperdense foci with surrounding edema. There is some misregistration there because they moved during the acquisition. And this is the appearance of their penile metastasis, which are very rare. This is our next patient. And the interesting finding here was that they had solitary bone metastases involving the left scapula. So here is the scapula in the bone window on the CT, and we see corresponding focal intense uptake. And here there was not much change in the trabecular pattern of the bone compared to the other side. So remember, when there is focal intense uptake, you may not find any change on the CT in terms of the trabecular pattern or focal disease, especially on the bone windows when compared to the other side. But still, when there is focal intense uptake, you have to call metastatic disease, and the bone windows on a CT may be normal. This is our next patient. They had very high PSMA, and on their rotating image, we see this multifocal disease involving the axial skeleton. We see multiple foci in the skull, the entire spine, sternum and ribs, proximal humerus, scapula, proximal femurs, and the entire pelvis. And their corresponding CT shows these multifocal sclerotic lesions. And so this is approaching a superscan pattern on a PSMA PET-CT, superscan pattern of bone metastasis. This is our next patient. They have extensive metastatic disease. And the interesting finding here is that we see this uptake in the left supraclavicular lymph nodes, which is also called Verocay's node. And there have been a couple of publications on how after the advent of PSMA PET-CT, we are seeing this finding more often in prostate cancer patients. The characteristic left supraclavicular lymph node uptake, also called Verocay's node. Here's a patient who was treated, and so this is the scan on the left, which is before treatment. We see retroperitoneal metastatic lymphadenopathy. We see the primary in the prostate, and after treatment, the prostate primary has become smaller and the retroperitoneal uptake has completely resolved. And so PSMA is pretty good for following up these patients to evaluate response to therapy. These are cross-sectional images showing the same thing: initial primary in the prostate becoming smaller, retroperitoneal lymphadenopathy showing uptake and complete resolution with no uptake seen on the follow-up scan. Here's our next patient. This patient had solitary uptake in a rib. And so sometimes we get into this situation where there is a single rib focus, there is no other evidence of bone metastases, and how do you tell whether this focus is metastatic or false positive uptake from a healing or a healed rib fracture? And so when we used to read whole body bone scans, we would look at the intensity of uptake, we would look at the pattern of uptake, whether it's linear or focal uptake, and spindle-shaped uptake with less intense uptake would be classified as probably healing or healed fractures, and linear intense uptake would be classified as bone metastases. So here, this patient's primary is seen right here, multifocal on both sides, and here is that focus in the rib. And so after their treatment, the prostate primary and uptake of PSMA there has completely resolved, but this focus in the rib remains, and that tells us that this is a false positive uptake from a rib fracture and not a bone metastasis, because if it were bone metastases, it would have responded also to the treatment. Here is another patient. I don't have the rotating image on this one, just a frontal projection and a lateral projection. And here what we are seeing is multiple symmetric appearing foci of increased uptake in both sides of the neck and also in both sides of the pelvis. They have soft tissue and bone metastases, which I will show you later, but this posterior uptake is very interesting. This is uptake in the thoracic and the sacral ganglia in the nerves. And so this is a bone met. These are soft tissue mets. These are more soft tissue mets, but these are uptake in the ganglia. So this is a false positive uptake in the ganglia, like a pitfall that we know of to avoid while reading PSMA PET-CTs. Here is our next patient. They've had prostatectomy, and remember I was talking to you earlier about funnel-shaped urinary bladder when they do a vesico-urethral anastomosis after they remove the prostate. And so this funnel shaped is seen right here. There is low density urine, which shows the radiopharmaceutical that has been excreted from the kidneys into the bladder. And so don't confuse this with recurrent prostate cancer. This is just how the bladder appears funnel shaped after prostatectomy. All right, so that brings us to the end of this series of interesting PSMA cases that we came across. I offer 2 on-demand courses through my website, www.nuclearmd.com. One of them is a radioisotope safety course. It is a 8-hour-long didactic on physics of nuclear medicine, and the second one has 100 clinical nuclear medicine cases, each associated with 4 multiple choice questions. Great for board review to prepare before your exam. Check it out. Also, I have published 2 ebooks, Nuclear Medicine Handbook and Cases and MCQs. These are available on Apple bookstores. Great for trainees and nuclear medicine technologists. The best part about these books is that there are short videos embedded in the book itself, and so you can play the video and look at a lot of different kinds of cases, just like the cases that I just showed you in this video. Thank you for watching.